Hello. Today I will discuss about blood cholesterol, blood lipids and its association with cardiovascular health and disease. As you know, we Indians are very much prone to have coronary artery disease. Our disease pattern is slightly different from the Western world. Not only we have very severe multivessel coronary disease, but we start the disease at an early age, say around 20 to 30 years of age. Our disease has got bad prognosis, outcomes are not very good. And it has got some unique risk factors association with it. All over the world, non-communicable disease is now the more important cause of death than the infection and communicable diseases. In India also, communicable diseases like tuberculosis, malaria, HIV are taking a back seat in comparison to heart attack and stroke as a primary cause of death and morbidity. Keeping that in mind, we have to be very aggressive in detecting the early risk factors in our population to prevent coronary vascular disease, cardiovascular disease in later years. Our lipid pattern, blood lipid pattern, is also different from the Western world. Sometimes it is called diabetic dyslipidemia, sometimes it is called atherogenic dyslipidemia, but we can characterize it as a very typical of Asian Indian dyslipidemia, whether associated with diabetes or not. Our lipid pattern is characterized by more or less normal or slightly elevated LDL cholesterol, which we know is the most atherogenic particle in the blood which causes the cardiovascular disease. But it is more characterized by a lower level of HDL cholesterol and a disproportionately higher level of triglyceride. Their atherogenic roles are established, but their treatment protocol is not very standardized as yet. Various Indian organizations like Lipid Association of India, Association of Physicians of India, Cardiological Society of India, they have come out with their own statements and guidelines regarding lipid management, which is particularly relevant to the Indian context. When we talk about lipids, we cannot stop talking about statins, because this is the only class of medicines which has unequivocally proved to be beneficial in reducing cardiovascular morbidity and mortality in the face of dyslipidemia. Over last 4 or 5 decades, statins have established themselves as the primary treatment for dyslipidemia, and of late, not only dyslipidemia, but any atherosclerotic cardiovascular disease, whatever be the status of lipid, statins are part and parcel of management protocol. Statins are chemically HMG-CoA reductase inhibitor, which is the determining step of cholesterol synthesis in the liver. So when statins act, they act at the very root of cholesterol synthesis. They also have some pleiotropic effects, and we will come to that. They not only reduce the cholesterol synthesis, they also increase HDL to variable extent of 5 to 15%. They also reduce triglyceride to some variable extent of 15 to 35%. And they also have beneficial effects of other lipid parameters like LPA, chylomicron, and intermediate density lipoprotein, which are clubbed together as non-HDL cholesterol. Its LDL lowering potency depends on the type of statin and its dose used, but variably between 20 to 55% on an average. Apart from lipid modifying effects, statins also have some pleiotropic effects, which altogether try to reduce the cardiovascular disease burden and acute attacks of cardiovascular disease like heart attack or acute coronary syndrome. Statins, apart from reducing cholesterol synthesis, also reduce the isoprenylation of protein, which is a very key step to reduce the inflammation. As we know, the atherosclerotic plaque, when gets inflamed, they tend to rupture and destabilize, and that creates the acute coronary syndrome or heart attack. So statins also have got a huge role to pacify or passivate the angry plaques. They also have multiple other pleiotropic effects, including the endothelial stabilization, including reduction of smooth muscle proliferation, including reduction of other inflammatory markers by phospholipase A inhibition. When to start statin and to whom? About 2 years ago, American College of Cardiology, American Heart Association has published a very elegant report on reduction of LDL cholesterol with statin and the use of statins. They have identified 4 groups of people who will benefit from statins. Top among them is the people who have already has evidence of cardiovascular disease in the form of heart attack, angina, stroke, TIA, carotid thickness or peripheral vascular disease. Second in line comes the people with diabetes with high other risk factors like smoking, hypertension, family history, etc. Third comes diabetes without other risk factors, and there are also the value just for the value of cholesterol with some markers of LDL and HDL without any other risk factors. That is the fourth group who will benefit from statin therapy. Different recommendations about statin therapy. There is certain variation among the European guidelines and American guidelines, but Indian guidelines take a middle part. For high risk patients, particularly those who have already got cardiovascular disease or who have got a 10 years projected risk of more than 7% for cardiovascular disease, they qualify for a highest intensity statin. Nowadays it is differently termed as high intensity statin rather than high dose of statin. By that we imply that the baseline LDL cholesterol should reduce to the tune of more than 50%. When we call intermediate intensity statin, we intend to reduce the LDL cholesterol by 30 to 50%. And when we call low intensity statin, that means our expected reduction of LDL cholesterol is less than 30%. But very few statins can achieve this high intensity target, that is more than 50% reduction of baseline LDL cholesterol. Only 2 agents are approved or touted as effective for this. One is rosuvastatin in the dose of 20 to 40 mg daily, and the second is atorvastatin in the dose of 40 to 80 mg daily. In the intermediate intensity statin, there are some more candidates, including rosuvastatin of 5 to 10 mg daily, atorvastatin of 10 to 20 mg daily, and here comes simvastatin, pitavastatin, bravastatin, fluvastatin also. And low intensity statin basically is a very low dose of statin like bravastatin, which are weak statins. How to monitor when a patient is on statin and what are the side effects of statin is sometimes an important and relevant question. There were fear about statin use as far as muscle side effects are concerned, liver side effects are concerned. But over time and with use of statin on thousands and thousands of patients over the world and over 10 years, 20 years of time period, it has been proved that though liver toxicity and muscle toxicity are known side effects of statin, but their occurrence is extremely rare, below 1 in 1000, sometimes below 1 in 10,000. It is monitored very easily by liver enzymes like SGOT and SGPT and by muscle enzymes like CPK measurements. About 5 years ago, it was recommended that you should routinely measure these enzymes at the baseline and then periodically in future. But nowadays, it is recommended that unless there is symptom of liver failure or jaundice or muscle aches and pains, you do not need to do routine tests as a baseline or as a follow-up. But when these symptoms come, of course, you have to judge whether this liver and muscle toxicity is directly coming from statin or there are some other incriminating cause. Those should be excluded first. Once those are excluded and it is more or less determined that the toxicities are coming from statin, then there are 2-3 options. One is to de-escalate the statin dose, to reduce the statin dose and to see whether the symptoms and biochemistry settle down. Second is to change the statin altogether and hope that a newer statin will have less side effects. Thirdly, you can give a holiday period with statin to take off the statin for about 3 months and recharge it to see whether the symptoms recur or come back. If at all it appears that statins are not really tolerated by the patient, there are certain alternatives. Which is the most on the cards is ezetimibe, which is by some newer evidence proves that on top of statin, they do a good job in reducing cardiovascular disease. But when statin is not tolerated, they can be used alone as well. But at every step, I would recommend that the patient should be taken in confidence regarding the benefits and side effects of statin. The benefits they accrue by taking statin for a long period far outweigh the perceptible, very minimal risk of some systems on the body. There is a risk, at least a perceived risk of increased cancer incidence with statin. There was some anecdotal evidence in favor of that, but so far in 2016, there is no convincing evidence that statin increase malignancy or change the prognosis once there is malignancy. As we know, statins are also useful in transplant surgeries to reduce graft rejection. They are also useful in advanced lung conditions as well. So they have got anti-inflammatory, anti-inflammatory properties very highly, and anti-infective properties as well, which can be used in benefit in terms of cardiovascular health as well, because there was a theory that atherosclerotic plaque rupture is caused by inflammation or infection. So statin also helps in that way, apart from reducing LDL cholesterol. What we would promote that statin should be used more liberally, but with a little caution that we are giving it to the right people in the right dose, and if necessary, we should know how to monitor statin dosing or statin side effect, and if necessary, we should not be hesitant to withdraw statin or reduce the dose of statin. In that way, I think we can do the best judgment to the statin, which is, to my judgment, is one of the most important discovery in the medical field in last 2 centuries.